English. And I will do my very best not to bore you all with it, let's say medical for what we're used to topic, but also try to encourage you to learn more about this so we can help more of our patients in Bauchzentrum. So why is alcohol-related liver disease a dual pathology? Because without having an alcohol use disorder, or at least an excessive alcohol consumption, people do not develop this type of liver disease. And the pathophysiology of ALD is not only medically associated, but also very commonly have psychiatric disorders, in some cases, severe alcohol use disorder, and in very severe cases, also patients that have severe anxiety disorder, depression, or PTSD, in addition to other primary psychiatric disorders like schizophrenia. So it is really not one discipline, it's not one disease, it's two diseases in one. And unfortunately, neither we nor our colleagues from psychiatry, psychology, or addiction have enough training or equipped to treat this disease alone. And so for this reason, there exists this term, integrated multidisciplinary care model, where here we have a specific role for each of the elements. We have a hepatologist, which can be a gastroenterologist. It can also be internal medicine specialist. It can even be a primary care physician. Then we have the role of a psychiatrist, addiction counselor, and in many cases necessary also nutritionists and social work. And how can this play? We're going to see later on the different tiers that can exist in this integrated care model. Ideally, and studies have shown this, we should have this all in a co-located setting, meaning all under one roof, meaning that we all work in the same place, that we center the attention on the patient, and we do it together. We know that there, and we'll see later on, various barriers to that. And so we do what, at least in our setting, we can do best. And these levels of care can occur in emergency department, in inpatient ward, in the primary care setting, or in a liver clinic like we have here. Why is this important? Well, epidemiological data shows us that it's not going to decrease. So alcohol-associated liver disease is on the rise, and we saw a huge increase in alcohol consumption, particularly following the COVID-19 pandemic. And this has consequently accelerated and increased the rate of alcohol-related liver disease and mortality. What we have alarmingly seen in this setting is an increase, particularly in young patients. We've seen an increase in the prevalence of alcohol use disorder, hospitalizations, need for liver transplant, and patient mortality. And among these young patients, what we primarily have seen in the last, and we also see this in Switzerland in our own clinic, is an increase particularly in women and also in racial and ethnic minorities. Here in this study published in the British Medical Journal in 2018 by a team of hepatologists, we see that particularly, as you see on the left side, the increase has been more in women, particularly young women. And we see that alcohol-related disease, alcohol use disorder, has primarily increased in individuals between 25 to 35. So let's say the common patient that we saw maybe about 20 years ago, which is usually a middle-aged man with a decompensated cirrhosis with ascites, has now, let's say, morphed or transformed a bit in terms of epidemiology more into a younger woman who's jaundiced presenting with an alcohol-related hepatitis. Here, this very interesting study published in Lancet Public Health, we see that age-standardized deaths due to alcohol-related disease are projected to almost double in 2040. At the moment, so in 2019, it was 8.23 per 100,000 persons years. It's predicted to increase to 15.2. And as a consequence, ALD, or alcohol-related liver disease, decompensated cirrhosis, is projected to increase 77%. Now, this is a modeling study where they looked at what if we do what we were doing up to now, so our status quo, which we see in gray in this graph. What if we do a moderate intervention, at least shortly speaking with patients about this? And then what if we do a strong intervention, which is, for example, an integrated care model? Can we actually, what is projected, what's predicted, can we change things? And I think it's quite clear, if you look at these graphs, that we can clearly decrease deaths associated with alcohol-related disease and development of alcohol-related cirrhosis with stronger interventions. And here, still on the topic of epidemiology, I just want to shortly highlight something that affects a lot of us in UVCM and in the liver clinic, and also in the surgical clinic, is bariatric surgery. and alcohol. I know many of us are aware of this, but not all of us are aware of this, that in fact, this is a really high risk group, and we're seeing many patients coming into our wards with alcohol-related hepatitis, particularly younger women who have had, in most cases, the higher risk surgery here is gastric bypass, where we see that they developed, number one, psychologically, a shift in their addiction, meaning they change food into alcohol. There's also, obviously, if you have a bowel surgery, you have an altered gut-brain neurohormonal axis. For consequence, if you remove part of the stomach, you're going to have a loss of the gastric alcohol dehydrogenase and also an increased reabsorption in the jejunum. Meaning, with smaller quantities of alcohol, you can really have a severe and accelerated liver disease. Here is a nice study that was published by the group from Ramon Bateer, who's an expert in this field, and they showed, out of interest, in the United States, if we compared alcohol use disorder in patients that do specifically bariatric surgery versus all other types of abdominal surgery, and we see also rates of alcohol-related liver disease, we see that it's significantly increased in the population that have been intervened with bariatric surgery. This is a study that we published in collaboration with a bariatric group. And here, I just want to highlight 2 points. Number one, something we already do here is that when we propose someone to do bariatric surgery, we evaluate if they have liver disease and what degree liver disease. But something that I'm not quite certain we do in such a regular basis and that we should do on a regular basis is certainly screen these patients before bariatric surgery. After bariatric surgery is very important to do it afterwards, because many of these patients previous to the intervention do not have an alcohol use disorder. They develop it after the bariatric surgery. So it's important to keep an eye on this. Now, why an alcohol-related care model? Why are we doing this? Number one, it works. So this here is a meta-analysis. In this meta-analysis, we can see that using a siloed treatment, meaning same place, we have addiction, psychiatry, and liver disease specialists, or liver disease surgeons or in the setting here in particular, in the liver transplant setting, we see that the rate of alcohol relapse is reduced by 44%, comparing the placebo or interventional group, and also patient mortality reduces by 71%. So we increase abstinence rates and we decrease relapses. This is particularly key in the liver transplantation group, but also has been shown to be effective outside the liver transplantation setting. Now, what degrees can we implement of an integrated model? So here we have, let's start at the bottom. Just having in the same city, so in Bern, a liver specialist and an alcohol specialist psychiatrist that treats patients would be enough. So let's just say unaffiliated. You send someone to a certain clinic. That's the lowest, but that's something already. That's already a form of integrated care. And then we can build up, meaning perhaps this hepatologist or a hepatologist or a group of hepatologists starts to form an actual informal relationship with certain addiction care settings, which we have at the moment. And then we have, let's say, higher degrees, being the highest degree, a co-located clinic in which you have on the same day, particularly new patients evaluated by a psychiatrist, addiction specialist, and also hepatologist, all in one. Here is an example. How can this referral pathway occur? First of all, it's dependent on us who see these patients with liver disease to ask them. We have to screen patients. We have to ask them if they drink alcohol, even if we think that they don't. Meaning, even if we see a woman who's 55 years old and overweight, and we think maybe she has a metabolic liver disease, you have to ask. We have to ask them how much they drink. It's up to them to report what they report, but it's up to us to ask every single new patient we see and follow-up patient how much they're consuming in alcohol. And it also behooves the colleagues from the psychiatry and addiction specialists to also at least do a liver lab, just to see if the patient has increased liver tests, and then refer to us if they see any changes. How does an integrated care clinic look? So this is a screenshot I took from a paper. This is from a group in the University of Michigan, Dr. Jessica Mellinger, who is a transplant hepatologist, and Dr. Scott Winder, who is an addiction specialist and psychiatrist. This is how they have set up their co-located clinic. If you see on the picture, the patient is in the center. a medical provider, that would be one of us, for example, therapists and psychiatrists, patients in the center, meaning this doesn't have to happen every single day. Possibly in an earlier phase, one could start doing this once or twice a month, which is what these colleagues did in the beginning. And so they pick 4 patients. In this case, they picked very high-risk patients, patients that would be eventually candidates for transplant, most of them with alcohol-associated hepatitis, and most of them younger patients. And so they distributed the clinic into different slots. Hepatologist sees the patient, psychologist sees the patient, psychiatrist, and then there's a discussion of the patient. What is the plan? And so this is done, for example, this is a morning outpatient clinic for this specific model. Who do we choose? Now, it's obvious that we don't have resources to treat in this type of model every single patient we see. Now, I think particularly we should focus on patients with severe liver disease, patients with decompensated cirrhosis, or patients with alcohol-related hepatitis, in particular patients that, for example, we saw in our own inpatient setting and that we will refer to our clinic. And I think if we have to go really to the only patients we can see, if we had to choose them, obviously patients that we would potentially refer for liver transplantation. Here, sorry for this slide, but here you have a summary of most of the studies. There are only 2 other studies that are not on this slide. These are all the studies that have looked at the experience of developing a clinic where you include addiction specialists and liver specialists in the transplant setting. And as you see, there are not that many studies showing this. And to summarize it, the setting here is overwhelmingly looking at patients who are worked up for liver transplantation and listed for liver transplantation. The number of patients is not high. It varies from about 300 to 200 patients. And every single one of the studies that I showed in the previous slide, there's always a liver specialist, an addiction specialist, and a psychologist. To summarize the various outcomes from the studies, this model has been shown to lower post-liver transplantation alcohol intake, to increase access to specific alcohol addiction therapy post-liver transplantation. And it's also shown that patients that have a short period or just a very on-the-spot integrated care actually have a higher rate of relapsing with alcohol consumption after transplantation. And in terms of liver-related events, we see that there's no difference in survival relapse in alcohol-related patients versus patients with alcohol-associated hepatitis versus alcohol-associated liver disease cirrhosis. And so how can we treat these patients? Well, first of all, we're not treating these patients. These 2 studies have shown how we are failing these patients. So only 10% of patients that have alcohol-related liver disease receive any type of treatment. I mean, even psychotherapy, behavioral therapy, only 10%. And if we actually look at the percentage of patients that receive, in this case, it was done in the United States, any FDA-approved alcohol relapse medication, 0.4%. If we look at this other study done by Rogel, also in the United States, behavioral therapy alone, 12% received it. Behavioral and pharmacotherapy, 1%, and only pharmacotherapy, less than 1% received that. So we need to start thinking about this as soon as the patient is admitted to us, be it in the outpatient clinic or on the ward. Here, I'm not going to go into detail, also because I'm not an addiction specialist, just to say that there are a few things that we can do. These are some of the examples of psychosocial or behavioral treatments that can be offered to the patients. And the first one, we can all do. It's true, it does take time, but we can all spend 5 to 10 minutes educating the patient what alcohol can do to them. And I mean really showing them, explaining to them that alcohol causes fibrosis, that it can cause complications of cirrhosis, that it can lead to death and complications, and also working on the patient's skill to open up regarding their alcohol consumption. That leads me to the second modality, which is motivational interviewing. And this is basically using open-ended questions, non-judgmental questions, to get the patient to open up about it. What leads you to drink alcohol? Or what's stopping you from having or seeking help for it? Or do you think you even have a problem related with alcohol? 3 simple questions you can ask to try to understand if the patient is willing or let's say, at least willing to receive some guidance or even specific therapy. Then there are other modalities, particularly in the addiction medicine setting, for example, contingency management. There are a few trials that have shown that if patients with alcohol use disorder submit a sample where you can do an alcohol blood marker and it's negative, they actually receive financial incentives. And this has been shown in trials to increase the rate of abstinence. And then getting to the core, which many of our patients do need, which is something called cognitive behavioral therapy, which is understanding why they drink, what led them to drink. Possibly it's something, and this is something particularly we have to be aware of younger women, is that in many cases there is sexual or abuse that's happened. And obviously this is something that's very stigmatizing and they don't want to relate it. And this is a lot of times something that has triggered their alcohol consumption. So asking what has triggered it, why do you drink, and in what situations does this happen, and then helping the patient, and this is obviously more for the addiction specialist, helping the patient develop coping mechanisms. So this is going to happen again. Maybe if you always meet X and Y friend, avoid meeting this friend in the future. Okay, what therapies can we offer patients that have alcohol-related liver disease? The first slide I'm dedicating to baclofen, because baclofen, which is a GABA B receptor agonist, and what it mediates is the decrease of release of dopamine, and so it decreases the feeling of pleasure that is associated with alcohol consumption. This is the only drug that was studied in patients with decompensated liver cirrhosis. The study is old. It was published 17 years ago by the group of Giovanni Dolorato in Rome. And I want to show you, as you've seen these red boxes, quite a high percentage of the patients included in this trial were patients with decompensated cirrhosis. So over 80% had child B or C. An important point I want to bring in terms of safety is that none of the patients had hepatic encephalopathy. Since this has obviously an effect in GABA receptors in the brain, the authors hypothesized that possibly this could worsen encephalopathy. So none of the patients had an overt hepatic encephalopathy. None of them had a history of epilepsy, and none of them had active psychoactive drugs. So we're talking about, let's say, pure liver patients. This is their first trial with therapy. And what the study showed was that it increased the rate of abstinence and decreased the rate of alcohol relapse in the trial that took place during 3 months. Since then, this has not been replicated. More recently, this was presented in last year's Liver Congress. There's a group from New Delhi who did a double-blind randomized placebo-controlled trials with naltrexone. Naltrexone is a known drug in addiction. It is a mu-opioid receptor agonist, and there have been a meta-analysis showing that it is efficacious in patients with alcohol use disorder. It's not so clear, and there are many questions related with pharmacokinetics and its safety in patients with liver disease, particularly decompensated liver disease. And here, in this study, the focus were on patients with compensated liver cirrhosis, so all patients were child A. And at 3 months, and using a low dose, so 50 milligrams, and not going past 50 milligrams of naltrexone, they showed that abstinence was 64% in the naltrexone group versus 22% in the placebo group. Here, also to mention that most common side effects were digestive and were light, so no severe side effects, and only one patient discontinued with therapy. Again, now we're waiting to see the full published paper, but this was quite an exciting presentation from last year. What about acamprosate? There is data showing that it works in alcohol use disorder, and in particularly in liver disease, we only have retrospective studies. We have, for example, this one published 2 years ago, which tried to compare acamprosate and, let's say, the gold standard baclofen in this group of patients with alcohol-related liver disease. And the main objective of the study was to look at liver-related events and also a secondary looking at side effects. And in this study, it showed that possibly it even had less side effects than baclofen. But again, this is retrospective data, but something that requires prospective studies. Here, you have a sort of summary of the drugs that are available to prevent alcohol relapse and alcohol-related liver disease. There are 2 that I didn't mention previously. One is gabapentin and the other is topiramate. And here there are also only not really dedicated studies in alcohol-related liver disease, and they both modulate GABA activity. Here you also have a summary of the dosage that is recommended in patients with alcohol-related liver disease. Regarded to baclofen, it's the study that we saw previously, that trial. The dose was 30 milligrams per day It's not recommended, particularly in decompensated patients, to go past that. If the patients are compensated or they don't have cirrhosis, one can go up to about 80 milligrams per day. Here, a special word and something that we do deal with and are dealing with actually presently in an outpatient clinic, in our inpatient clinic, is withdrawal. And in the particular word here is just the type of drugs that we use. So we know that benzodiazepines are a cornerstone of therapy to reduce withdrawal symptoms in patients with alcohol use disorder. In patients that have liver cirrhosis, please bear in mind that one should use a drug with a shorter half-life, like lorazepam and oxazepam. And also bear in mind that it's many times extremely difficult in these patients to distinguish what's an hepatic encephalopathy and what is a withdrawal. And besides this, obviously, high-dose thiamine for all the patients. Here are just two short slides about new and exciting drugs that are also interdisciplinary drugs. In this case, we're talking about the GLP-1 receptor agonists. So we know all the hype of it regarding obviously diabetes and obesity with proven trials. Now, at the moment, there is a trial running from Novo Nordisk, which are the manufacturers of semaglutide, where they're looking at patients, specifically patients that have liver disease, and their primary endpoint is liver-related fibrosis regression. But as a secondary endpoint, they have established to evaluate alcohol consumption. And why have we seen this? Because in preclinical rat models, it was shown that giving it affects GLP, the reward center, and decreased alcohol consumption. There was a trial that was published 3 years ago by a Danish group looking at just patients with alcohol use disorder, not patients with liver disease, and it was negative partially. There was a subgroup of patients in this study, 30 patients that were obese, and it was effective in this particular population. And this is a population that we have quite often in our liver clinic, patients that are overweight or obese and also have an alcohol use disorder. So this is something that we currently have registered in our center, a trial to look at GLP-1, and now we're waiting to find funding so that we can start that as soon as possible. A short word for fecal microbiota transplantation in alcohol use disorder and ALD. There have been more studies looking at FMT, in particular in decompensated cirrhosis, but the group from Josh Bajaj has published already 2 studies. One we see here on the left, it was the first phase 1 trial looking at implementing fecal FMT enema in patients that have alcohol use disorder and liver cirrhosis. And the primary endpoint was to establish that it was safe, and it was established. They moved on with this paper that you see here, the study that was published 2 years ago in Nature Communications, where they took those feces from the patients, the same patients, pre-FMT, post-FMT, and they colonized germ-free rats with both of these. And they saw what happened. And what they saw was that the rats that were colonized with the post-FMT had consumed less alcohol than the other group. So this is something that obviously still needs exploration, but it's an exciting field. A short word, tactic that we've used for many years, which is you need to stop completely. Stop. See you in 6 months. Not the most effective. And we know that there are patients who are either not willing or not capable of completely stopping alcohol consumption. And in these, there is really a place for something called harm reduction, which is establishing with the patient goals. If you're drinking at the moment 2 bottles of wine, and you can try to reduce it to 1 or 1.5 liters of beer, that is, for me as a liver specialist, a win. There is at the moment, but there are studies running, still no evidence to show that reducing highly alcohol consumption is necessarily going to prevent liver-related events. But let's say logic stands to show that it would. So here I think that gold standard is without a doubt, if you have a decompensated patient, a patient with an alcohol-associated hepatitis, the gold standard is always to try to motivate the patients to completely stop. But significantly decreasing is nonetheless an important goal, and it requires more studies. What's stopping us? Why are we not doing this in all of our patients? Well, as you can see in this slide, there are many barriers. Let's start with the patient barriers. Number one, some of them are not even aware they have a problem, or they don't have enough insight on the matter. Some, unfortunately, are too sick due to their liver disease to receive at least pharmacotherapy. Some don't report how much they drink, so we won't know. And obviously, stigma is huge in this population. So some people don't feel well, they just meet you in a liver clinic once, they don't feel open enough to talk about their addiction problems. And many of them don't have any social support. So in green, we see on the bottom some things we can do. A brief intervention, which we mentioned previously, educate the patients on the harms of alcohol, try to be as non-judgmental in our physical and also verbal behavior, and try to educate the patients and also involve family if possible. Then what about clinician, our own barriers? We don't ask patients if they have an alcohol use disorder. We feel a lot of times we don't have enough time to actually explore it well enough. We don't have training. We don't know how to deal with it. And we actually sometimes don't realize what is the significance of it in the disease. And so here, obviously, we need education from our side. And sometimes, and this actually has sparked me to think of building maybe an educational course with the colleagues from psychiatry and UPD, specifically for physicians, so non-addiction physicians, where we can receive some basic training in motivational interviewing, brief intervention, and even pharmacotherapy to try to see if we can help as many patients as we can. And then more difficult is we have systemic barriers, meaning it's more cost for the patient because they have to see two specialists. Insurance coverage, it's difficult to arrange in the outpatient clinic that you can have a psychiatrist, have a care manager, have a hepatologist, all, because we have the limited space. So these are all things that are difficult, but we need to find ways to break these barriers down. I just want to have a short word about the role of using alcohol markers. The role of using alcohol markers, meaning either direct or indirect methods to detect alcohol consumption, is not because we are working as police. The role of this is to detect earlier than later if there is unreported alcohol use, so we can facilitate an early abstinence program and refer patients to addiction medicine. And in some cases, to actually correctly diagnose the disease, because we can be assuming that disease is related to one etiology, but actually there's another etiology. Many of you have heard, if you're working in the Bauchzentrum, about an exciting marker called phosphatidylethanol. Phosphatidylethanol is derived when phosphatidylcholine is exposed also to ethanol. And what happens is phosphatidylipase specifically is more attracted to ethanol, does not digest or do not break down phosphatidylcholine. And what happens is that you have high numbers or high levels of phosphatidylethanol and less production of phosphatidic acid. As far as we know, then these are phosphatidylethanol is incorporated in red blood cell membranes. It is a direct marker of alcohol. The only false positive known until now in studies that exist, which are quite poor and small, is the use of recent transfusion from someone who has consumed alcohol. So this can give it. As you see in the bottom left, the detectability can go up to 4 weeks, which is let's say, very positive point. And besides this, in comparison to other markers, it gives us a quantitative idea of how much alcohol is being consumed. At the moment, it seems like it's not influenced by gender nor age. Whether or not it's actually influenced by liver disease is not clear. And for that reason, next year, we're going to start a study in our clinic and in collaboration with University Clinic of Basel and with the Institut Rechtsmedizin to look at what is the effect or what are the levels of phosphatidylethanol in patients with, let's say, a more early liver disease versus patients with decompensated liver disease. And so how can we use PEth? Well, we can use it to detect alcohol consumption. This is a very interesting study, which if you see, the underreported rate is quite high. 60% of patients don't report their alcohol consumption. But actually, when you look at a liver clinic and you compared PEth levels in patients with alcohol-related liver disease versus patients without alcohol, so autoimmune, metabolic, you actually see that the rate of PEth positivity is very similar, meaning that underreported alcohol consumption is not only in the alcohol-related liver disease group. And is it impacting it? We see that already in our everyday practice. We regularly screen patients who are actively listed for transplant. And in this graphic on the right, you can see very clearly in this graph that in blue is the pre-PEth era, 2017. In red is the PEth era, and here we see that the delistings has massively increased because we are using PEth regularly. So this will have an impact, obviously, on our patients. As a conclusion, I want to highlight, without a doubt, this is a very challenging field, but this is a field that we need to tackle early on because, as you saw in the epidemiological data, the tendency is this to increase in the next years. We have to either in our own training as gastroenterologists, hepatologists, integrate somehow addiction or create as closely possible, mostly disciplinary teams, so that we can properly treat these patients and put the patients in the center. We have to make efforts to overcome barriers, all of the barriers at every level. And we have to, and this is probably the most difficult, eliminate stigma that exists in society, in our local hospitals and within our patients, and to increase care for alcohol use disorder in our liver disease patients. Thank you very much.
Vielen Dank, Susana, für dieses sehr klare und sehr ausführlich, sagen wir, Überblick über dieses komplexe Thema. Vor kurzem wurden auch ein paar Daten vorgeschlagen über die Effekte von neuen Medikamenten oder von zum Beispiel die GLP-1s. Kannst du ein bisschen mehr daran uns sagen? Gibt es schon mehr Daten oder nicht im Moment?
So, leider nicht. Also die einzige Randomized Controlled Trial ist diese die wurde in 2021 publiziert und da man sieht nur, das ist wirksam, das ist ohne Patienten mit Lebererkrankungen, sind Patienten nur mit Alcohol Use Disorder und da hat man gesehen, dass in der so Overall Cohort es gab keine große Wirkung, aber in diese, sagen wir, Subgruppe Patient mit Adipositas, man hat klar gesehen eine starke Wirkung. Und es ist auf diesem Grund, dass wir werden hoffentlich, wenn wir Funding haben, unser Trial machen, insbesondere in diese spezifische Gruppe, weil wahrscheinlich Alcohol Use Disorder bei Patienten, die adipos ist nicht gleich wie andere. So Alcohol Use Disorder ist nicht gleich bei allen. Aber im Moment gibt es kein. Wir warten auf, was kommt von dieser Novo Nordisk Trial mit Semaglutid. Ja, gespannt. Aber nein, keine neue Trials oder sagen wir schon. Ja.
Vielen Dank. Gibt es Fragen für Susana?
Vanessa, thank you.
Yeah, thanks, Susana. I really commend you on always looking after these patients, which, as you say, don't only get stigmatized within society, but also very often from us doctors, right? We're not good at looking after these patients. I've got two questions. My first question is, if you would give one simple advice to somebody who sees a patient where you think that they're consuming alcohol and it's relevant for you as a doctor, as a surgeon, or as a non-surgeon, to at least have an idea how much they drink, how do you ask it? Do you upfront say how much you drink? Do you say, do you drink 3 bottles of wine per day? So what would be, because we're all not trained, as you say, how would you start a conversation in a patient you see for the first time, but it's important to try and estimate the best how much they drink? That's my first question. And my second question is the whole problem with pets and people who have a bypass. Are there any data that in these patients you can have false high pets, even though they've just like literally had a cough medicine with a bit of alcohol in it?
I think thank you very much. These are really very relevant questions. Regarding to the first one, I think that's also very cultural. So if I'm in a clinic in Spain or Portugal, maybe I'm not going to ask it the same way as in Switzerland. What I generally ask is, first I ask a lot of times patients what they eat. And then I say, what do you usually drink when you have dinner? And that's a sort of, I'm asking about nutrition. You know, it's a non-judgmental way. And if they say, and I say, well, but do you ever, have a glass of wine or beer, or maybe after work? So in the setting where we usually see people consume alcohol. And generally, I have to say that people are more open. We know that there are specific groups, particularly young women, where there's more stigma and it's more difficult. But here, I think the role of PEth is, bringing it to your next question, I think is really helpful, because it's a really non-judgmental way where you can see, listen, it's not me saying it. There's this test. And this test is an objective test. There's no really false positives, which means that we have to address this problem. There is alcohol consumption. Regarding the question you asked, there is no data. So there's absolutely no data, not even actually really reports regarding what are the rates, or let's say the quantitative levels of patients who drink alcohol and who have a bariatric, particularly patients who have a gastric bypass. Now, I think it's, let's say, quite logical that if you're not, and if you're losing enzymes from the stomach, so there's going to be much more ethanol that's reaching your system, meaning there's going to be much more phosphatidylethanol that is produced. So we see this with the fewer patients that they have extremely high PEth levels, and then we look at their liver tests and it doesn't really reflect that, which means that they probably are drinking, but not massively. This is for sure one of the things we're going to address in this PEth study we want to start next year.
Thanks, Susana.
Vielen Dank. Gibt es noch Fragen?
Okay, then I still have another question. The whole discussion with regard to stopping alcohol prior to liver transplantation. We all agree that we can't transplant an active alcoholic. Do you think we are too stringent? Do you think, you're saying harm reduction, if we accept that a patient who's had a lifelong of alcohol, who lives with people where it's normal that you have 2 glasses or 3 or 4 glasses of beer every day after work. Do you think there's any room, like we don't ask for our obese patients to lose weight, right? We never say you have to lose weight, you have a metabolic liver disease, and this is why it's cirrhotic. Do you think there would be a place to sort of come up with a plan that you say, look, you need to reduce 2 liters of wine per day is not okay. A glass or 2 of wine per week is okay, or do you say no, in these patients it's not going to work, they're just going to start drinking again a heavy amount?
Obviously, I don't have, as you know, unfortunately I don't have evidence to back this up. So there's no data to say if we tell liver transplant candidates you can reduce it to 1 glass a day, that's okay. The danger, as you know, is that some of these people don't have a severe alcohol use disorder, but many of them do. And so we know, and not from us, but from addiction medicine, that sometimes it's a sort of a gateway. So if you allow yourself to have 1 or 2 glasses of wine, so our brain is wired to then say, well, then maybe if we have, half a bottle, and so the tendency is then to increase. And this is actually a very interesting point, just quickly, alcohol-free drinks. There is some recent data showing that patients that drink alcohol-free drinks before liver transplantation have higher rates of then relapse after it. This is something that just with this we see. So I think in this setting, we still have to be strict and try to really get our patients to be complete teetotalers.
And so you also would say, if somebody says, yeah, but I've now switched to alcohol-free beer, that would be a red flag for you.
Exactly. This is someone who I'm thinking, because the whole idea is breaking habits, meaning, either avoiding certain people or avoiding certain habits that have been not healthy. And so we have a few patients who do, and I ask them, try to reduce the amount of alcohol-free drinks you have and change it with other types of drinks, because it's something you're going to have to institute for the rest of your life. So I'm not going to say you can't have them, but I do, because we also know there's a very residual amount of alcohol in them. So it's more about breaking habits and behaviors.
Sorry, just one last question, because everybody else is obviously drinking their first glass of wine and not listening anymore. Is there a way, because when you have these conversations with the patients, it takes quite a lot of time. Is there a way that we can reflect this in our DRG so we can at least get a bit more money for the conversations that we have with the patients? What needs to be in your report where you can say it was, complex behandling or
yeah. No, I do that. So all the patients that have the, AUD and alcohol liver disease, I put them as complex. So in the Abrechnung, I put complex Behandlung.
And what needs to be in the Bericht for us surgeons who occasionally also do this? Do we need to put a specific sentence? Like
I would say that we specifically asked about it. We educated the patient on what to do, or in some cases, we actually start pharmacotherapy in the like baclofen or camprosate in the outpatient clinic. So I think at least one sentence saying, we addressed this issue, we have realized this is an issue, or we referred or at least encouraged the patient to do like a rehab or to receive help from addiction specialists.
Ich kann dir noch anfügen, weil wir gerade die Abrechnung anschauen. Es ist ein absolutes Muss, dass explizit klar geschrieben ist, was ihr mit dem Patienten besprochen habt, sonst könnt ihr diesen Punkt nicht abbrechen, weil die Krankenkassen beanstanden ihn und aber auch der Patient. Und das ist relativ heikel, wenn das halt in einem Bericht steht an den Hausarzt und sonstige Verteiler, dass der Patient trinkt und was ihr ihm empfohlen habt. Da müsst ihr gut aufpassen, was ihr schreibt, aber ihr müsst wirklich schriftlich festhalten, sonst könnt ihr es nicht abrechnen.
Vielen Dank. Ich glaube, leider müssen wir hier stoppen, weil gibt es ein Tumorboard. Herzlichen Dank, Susanne. Es war wirklich
Sehr
sehr
gerne.
interessant für alle. Vielen Dank. Schönen Tag.
Tschüss.